that's 1 minute. You can put that aside. We will pull it back again. But I thank you for your participation in our shared learning as we're an earnest group of people learning together. I'll share with you, when I hear about equity, I think about lots of things. One of my first understanding and a practical application of equity is I started my career as a classroom teacher. I worked in Northern California for several years. And as a kind of new educator, I worked in a district where there was, the district was actually 93% Spanish-speaking, lots of migrant individuals that lived in our district. And I taught in the section of the district that was fairly impoverished. It was a great school district, and then there was this one section of the district where primarily white people lived, high net worth individuals. And I, as a teacher, was struggling basically with support and assets for my classroom. And in my naivete, I was thinking about how understaffed I was and undersupported, supporting individuals with significant disabilities, that I looked at the data because, as we learned today, like if you just shove data down people's throat, it definitely results in change. And so I looked at the data, and the northern part of the district had many more supports in the classroom, and I was really just looking at, in some ways, just the numbers of paraprofessionals and educators that were supporting the numbers of children, just the volume measure. And I thought, oh my gosh, this is the problem. This is why I'm struggling, is I don't have the proper supports like we do in the Northern District. And in my ignorance, I thought, people must not know. People must not know about this. So I volunteered to present this at the special education meeting with all of my colleagues, including the special education director, and then presented the data about this inequity. And then I also, of course, in my naivete, shared the racial data of these two sections that was publicly available and said, oh my gosh, we have to do something about this. There's such this inequity. And I was met with silence and kind of that's great. And then every time I requested to speak at another special education meeting for my 18-month tenure at that district, I was denied. And so I just realized, that was, when I think about equity, I think about how everybody, I just want everyone to get what they need. Fair is not the same, but I know that the section of the district was under-resourced, and so at 21 I learned that lesson about equity and disparity, and it still sits with me 24 years later about what equity means to me. One of the other individuals I like to think about is Dr. Paul Farmer, who recently passed, and his quote, "The idea that some lives matter less is the root of all that is wrong with the world." Dr. Farmer started an organization called Partners in Health, based in Boston and working around the world. And he has some amazing written words, a book called The Pathologies of Power. His autobiography is Mountain Beyond Mountain. And there's a movie on Netflix about his life called Bending the Arc. And so this quote sits with me. And thinking about working upstream, Dr. Farmer was also the person who taught me about, the first person when I started to understand about working upstream. One of his first efforts was to eradicate tuberculosis from Haiti. And he's a physician and a medical anthropologist. And as a physician, he was treating tuberculosis and drug-resistant tuberculosis in Haiti and was not having the impact that he wanted to have. And the individuals for whom he was providing treatment were, not drug compliant, were doing, he just wasn't getting the desired outcomes for tuberculosis, for which we do have treatment for most. And what he realized was you can't just treat the individual, you have to look upstream at issues of poverty and issues of resource access. And so you can have the best treatment you want, but if you're not looking upstream to address the core issues that are resulting in that inequity, you will never solve for the disease either. This is a QR code for Poll Everywhere, if you guys want to kind of grab it. I'll be using it throughout the presentation. Some of us are here together, and then there's another couple hundred people that are online. Poll Everywhere is just a nice way that we can use, we can respond together and engage in shared learning and see some other people's perspectives throughout the day, throughout this hour. It will ask for your name. I have set it up for everything to be anonymous, so no worries. So if you haven't used Poll Everywhere and it's asking for your name, you can use a pseudonym, you can put in anything, but if people can, and if you prefer to use the URL, the URL for this poll as well. And I'll just give everyone a minute to get set up. One of the joys of hybrid learning is that people can participate from everywhere. And then one of the things I miss is the shared engagement of all of us being together. So I like to use some of these processes to help us learn together. All right, I'm going to go ahead just to get us an opportunity to practice, and why not? I'm going to launch the first poll. And it's what brings you joy consistently. I'll activate it. Sorry, I'm doing it off my phone. You guys see that yet? Yep. Oh, your son, amazing. And you guys should be able to see these as well, those of you participating. Family. Dancing is one for me. Animals. I'll flip back to this one if you didn't pick it up. Thanks, you guys, for typing in. You can answer as many times as you want. I apologize for that. Some people are getting it and some people aren't. All right, we'll use them, and those of us that are here, we can talk about it as well. So a little bit about the current context we're working in, and people have talked about contextual, what's kind of happening in our society and where we're working right now. So 8% of Fortune 500 CEOs are women. 6% of full-time faculty at degree-granting institutions are Black. In the US, about 13.5% of our population is Black, so just speaks to structural racism. 62% of children who experience extended periods of poverty in childhood graduate from high school. The national graduation rate is 86%. Sexual minority youth are twice as high as their peers to report a desire to die. 27% of US Congress members are women. If I hear one more time it's the year of the women in Congress, I'm going to lose it. It's 27%. Annual median earning is $10,000 less for people with disabilities. 35% of transgender youth have experienced a physical assault. 33% of doctors associated obesity with noncompliance, hostility, dishonesty, and poor hygiene. And whoever just typed in bourbons, I'm so there with you on the shared poll here. 40% of our incarcerated adults are Black. So again, 14% of the population is Black, 40% of incarcerated adults are Black. And hate crimes reports in the US surged to the highest levels in 12 years in 2021. So that's the context that we're living in and what we have the opportunity to change through our shared effort. A few more data points. We know life expectancy is often a common measure of quality of life. And of course, life expectancy is strongly correlated with household income. So again, poverty impacts your life expectancy. And then in behavior analysis, just pulled a couple of the data here. It's so great that we're collecting this data now because we can actually analyze it. So with gender, we know that 85% of the BACB certificates are women, 37% of editors of behavior analytic journals are women, 20% of presidents and past presidents of ABAI are women, and 17% of ABAI fellows are women. So we value women as a workforce. We do not value women in leadership positions. And then when you look at race and ethnicity, similar data around Hispanic and Latinx. So 27% of RBTs are Hispanic and Latinx, 25% of BC ABAs are Hispanic or Latinx, and 11% of BCBAs, BCBIDs are Hispanic. So whenever you see data like that, you just know it's sexism, racism, because there's no other way to explain that in this way. So really looking forward to being able to impact some of this over time. And then for the most part, most of my career, I've worked with people with autism. So looking at kind of quality of life, people with autism, life expectancy much shorter. Employment is amazing. I also like this data here because we often think about a person with autism gets a job. So if I was still in my original job, I'd be working at Arby's, and I had the opportunity to have a career, not a job. So I really think about employment. The 38% of employed adults with ASD report being underemployed. So you want to think about employment, but then you also want to think about career pathways. And then disconnected. We're seeing a lot more data about suicide and death by suicide, suicidality in autism, and how it's much more prevalent. Race and ethnicity, new report that just came out this year around health and health outcomes for autistic children. And then this last one that Doshi did, I think this is really important because in autism services and supports, behavior analysis, we're pretty proud of our efforts to get insurance coverage for individuals on the spectrum. But often when you have policy changes, who it primarily impacts is the people that already had services. It gave them another way to pay for services. So when when insurance coverage first came through for behavior analysis, Medicaid didn't come along at the same time. We didn't advocate for that, or we had to acquiesce to that, and that's what happens sometimes with policy is it's incremental, and it just is. But it means that our job is not done. We can't throw a map up that says we've got coverage in all 50 states, because not everyone has coverage in all of those states. And who is usually left behind are the people of color and the people in poverty. So, we have continued work to do to ensure that every state has adequate coverage for all individuals. And then this is from Drexel. They have a public health institute in autism. They do some really good work. And this is just thinking about Medicaid beneficiaries for autistic adults. And again, it just shows the profile there of different race and ethnicities and where they're falling on kind of chronic disease. And again, whenever you see disparity like that, we know we have some work to do to ensure that there's kind of a consideration for what's impacting people's health. So our context where we're working, and we all know that we're experiencing significant disparity. And I'm excited to think about conferences like this where we get to talk about these things and address them, think about how this impacts our work and what we could do to change this. Skip that one. I really am empowered by the social movements that are happening today. So I look at the movements that are, the Me Too movement, Black Lives Matter, and I'm thinking, man, these people are really rallying change. And what could we learn from them? What could we do? How could we ensure that there is equity in our work? And so, I feel like the fact that there's increased acknowledgement and increased understanding at a macro level allows us to take that understanding and implement it in our work in our shared environment. Your workforce understands that there's issues of equity. So when you want to talk about equity within your clinic, or you want to talk about equity at your university, there's already a general understanding because we have these social movements that are demonstrating it for us. So Black Lives Matter is not unknown to the individuals who are currently attending Endicott, right? So they understand that there's kind of racial disparity. So when you want to dig in and have a conversation about how you could address it or how we could address it in behavior analysis, you're not having to actually explain structural racism. There's already an increased understanding of that. So I feel like that has, opened up opportunity for us to have increased discourse, increased dialogue. And all of these things happen, right, because of a power imbalance. And we have these power imbalances in every aspect of society. I am a person who certainly carries significant privilege. I was raised by a family that had incredible value for education. I was born white. I am a daughter of immigrants, but I had almost every opportunity. I was born on third base, I like to say, right? So I was born on third base. I did not hit a home run. And so the opportunities that I've had are because of the power that I've been afforded. And so thinking about that, how do we adjust those power imbalances? And how do those of us that carry significant power encourage, support, raise up those that do not? Because same as you, right? Wanting things to be equal, we're not different. We're just the contingencies, the experiences that we've had have resulted in these disparities and these inequities. But we can change them. We can absolutely change them. And one of the ways we can change them is thinking about social determinants of health. I have been a behavior analyst kind of from the get-go. I was an educator working in autism, got fortunate to be assigned to a school in the 80s that was using behavior analysis and learned. And then I got really interested in another discipline and went back and studied public health so that I could think about kind of some epidemiological processes and things like that, and got introduced to social determinants of health. And that's kind of been my work around health equity and thinking about equitable practices since then. So as Cody said, it's nice to think about vocabulary and that we're all on the same page. So this is from the Centers for Disease Control. And social determinants of health are conditions in the places where people live, learn, work, and play, and they affect a wide range of health risks and outcomes. And these are, sometimes they're broken up into different categories. I'm going to show you a couple, but they're really just these, kind of categories: healthcare access, neighborhood and built environment, social and community context, economic stability, and education access and quality. So kind of these macro things that really impact health equity and health outcomes, education equity, education outcomes. And the World Health Organization shares that the social determinants of health are mostly responsible for health inequities, the unfair, and listen to this, and avoidable differences in health states within and between countries. And that's the word for me, it's the avoidable, right? We can change these things, we're choosing not to, right? So how do we make that inequity? How do we address that inequity? How do we think about things that are arbitrary and perhaps even capricious of geographical borders and address them so that those avoidable differences that's creating inequity can be overcome? A little history about social determinants of health, kind of in the Wayback Machine, Industrial Revolution. That was kind of the first time that people started to think about the roots of disease were social, not just biological. So there was kind of some social constructs that were being laid on top of disease. And then in 1948, the World Health Organization changed the definition of health to a state of complete physical, mental, and social well-being. So the World Health Organization, that's how so sometimes you'll hear people say, health is not the absence of disease, right? So health is the complete physical, mental, and social well-being. And then we move forward a few more years, 30 more years, kind of as we're watching social determinants of health come into understanding. This was at the International Conference of Primary Healthcare in 1978. And so primary healthcare physicians were together talking about what's the importance of their work. And they were acknowledging that really to engage in primary healthcare, you have to have the coordination of other sections: food, education, housing, public works. So you can't just think of it treating the disease, right? There's all these other coordinated efforts that need to happen. 1990s, the World Bank really started to come into health. And in the 90s, the World Bank actually was investing more in health. So the economic strata was investing more in health than the entire budget of the World Health Organization. So we have this crossover of economics into healthcare. And then the WHO Commission on Macroeconomics really included kind of the economic aspects of health. And they started talking about social determinants of health 2002. And now in the US, dozens of bills are before Congress that mention social determinants of health. We currently have the Improving Social Determinants of Health Act that's in Congress being considered. So now we really understand that if we want to impact health outcomes, quality of life, you have to be addressing those categories of that we just discussed. So that's where we are with social determinants of health, and I think it's just becoming more and more. Most health plans are requiring assessment. Those of you guys who bill against insurance are going to be pushed against and say, how are you addressing social determinants of health? It's not just going to be an access issue, it's going to be how are you also helping families address issues of housing, food insecurity, what's happening for the referral for those additional areas. I think about it from a treatment capacity, right? And we know this, that especially here in the United States, is your healthcare access is related to your employment, which is so odd for me. Like, so you have to have a job to have insurance. We have some exchange as well, but so if we know that a family is about to lose their employment, then they may also be losing their treatment, right? So what's our responsibility as clinical providers to support those individuals to maintain and secure employment if they need that to maintain integrity of care? And I think those are questions that we should be asking each other and building resources and supports to ensure that families continue to have access. If social determinants of health are new to you, I think the Kaiser Family Foundation does a really nice job of describing what these kind of are. So economic stability are those categories, kind of read across there. And the education one is often where I think behavior analysts think that we probably have greater influence. And it's not a matter of doing all of these things, but it is understanding how they're all coordinated and what is your responsibility if perhaps you're working in the school environment. How do you know how to access these other categories of support, right? What are the resources that are available to the children in that school environment so that if something were to happen, if there was some other additional need, do I know where to go for it? So I may not, we talk about scope of practice, housing. I'm not a housing provider. I don't provide housing. However, I may be connected to my community in a way that I know where if people are housing insecure, I can make a referral and I can make a support. I'm able to do that. And if you think about just the trail down, right? School environment, if you lose your housing, you are often into a shelter, which then results you into a different housing sequence, right? Or different schooling sequence. So again, you're making all of these switches that have such an impact on the continuity of care for our children and our adults as well. So thinking about social determinants of health, thinking about looking upstream, thinking about how do you build capacity in these areas and understand that it's not just about the skills you're teaching in that treatment environment, but that kind of whole other aspect of this person's life that I can be a protective factor for, right? And I can be a supportive factor for because of it. And it is what results in inequity when we don't do that. We think about it sometimes, we want things to be clean, right? Like you get higher education, you have better health, your health is good, you're able to access education. If you get a higher education, then your socioeconomic status is going to be great. And then, if my economics are good, I can influence the political landscape, which results in better education and better health. And really, it kind of looks like this. It's complicated, right? It is messy. And I think I joke a little bit about my level of rigidity. I'm like, I'm such a rigid person. I think I chose behavior analysis because I am a bit rigid. I like things that are ordered. I like my data. I like my information presented in that way. This is messy, right? And sometimes it's uncomfortable when the people for whom we're providing support start asking us questions about, oh my gosh, is there support for my co-pays? Sure, uncomfortable. I'm a little uncomfortable, right? But if I can't pay my copay, I might stop showing up for my health appointments, right? And who better to ask than me, who's equally as dedicated to support your child's well-being, right? So let's think about that. Is there familial support? Is there information that I can provide? Have I built the capacities to support this family? And be a little bit comfortable in that messiness that is the human condition. So, dig in, build relationships, connect with other people, and get comfortable with the messy, because we're dealing with humans, and humans are invariably messy. Your second attendance code, I'm going to get it right this time. I'm going to look right at it. LAV8K2. I'd like some reinforcement, please. All right. Here's some of the organizations that are kind of work in the social determinants of health space. And I'll talk just about one of them. Obviously, the World Health Organization spoke about that, Centers for Disease Control. Center for Medicare and Medicaid Services, I'm not sure who many of you may be, or some of you may be billing against Medicaid, really starting to invest in social determinants of health and requiring their providers to develop measures of how they're addressing social determinants of health. American Public Health Association, that's the body that guides my work in public health. And then the last one is Healthy People 2030. Right now it's 2030. And Healthy People is kind of our societal measure of overall health at a macro level. There was Healthy People 2010, 2020, 2030. And it's a function of the Office of Disease Prevention and Health Promotion from the Health and Human Services Office. The CDC is the statistical arm, so you'll see the data come out of the CDC. And the goal is to attain healthy, thriving lives and well-being free of preventable disease, disability, injury, and premature death. And basically, every large government organization is engaged in Healthy People 2030. Departments of Education, Departments of Health, Departments of Human Welfare. I mean, everybody is engaged in this work to try to measure the impact at the societal level and at that kind of scale level to do this. There's 509 objectives that are being measured. I'm just going to talk about one as a reference that many of us are impacting, probably without even knowing that this is having, that you're engaged in this work. And Healthy People is, again, I think it's one of the biggest projects, if you will, of our society to measure health outcome of our nation. And I think getting engaged in the work of Healthy People 2030, knowing where you fit. I talk to many behavior analysts at times, and they're like, I want to get engaged at a kind of more systemic level. And I'm like, do you know about Healthy People 2030? Do you know who the people are in your state that are, or in your region that are working on this? It's a really nice way to try to kind of move into an environment. One of the objectives of Healthy People 2030 is to reduce the proportion of adults with disabilities who experience serious psychological distress. And they have the data that they're measuring against. They have the measure that they're using around this. You can dig in a little bit further to see what they're describing as experience serious psychological distress. But I know that we actually have impact on that in behavior analysis. We work with adults with disabilities. We work with children so that hopefully they become adults who do not experience serious psychological distress. And if you look at these numbers, there's 8.7% now, shooting for 7.6%. They're using these data to try to assess impact. I sometimes think about, you can also dig in at a state level to see where your state fits. But there's these, again, 509 objectives across different measures that they're looking at to try to address these things at a macro level, looking upstream. Other related objectives in disability, there's also objectives not in disability. I just know most of us work in the disability field. Students with disabilities who are in gen ed, adults with disabilities who delay preventive care, right? So women with cerebral palsy die of cervical and other gynecological cancers at higher rate because gynecologists don't perceive that they can get on the exam table, right? So how do we change that? So there's just other objectives. So I share this with you, and we'll start talking about working upstream, because this is upstream. This is trying to address the upstream equity issues. So working upstream, this is kind of a parable that is in public health. And upstream, we think about kind of community impact, individual impact as you go down. And then the downstream is providing clinical care. Midstream, addressing individuals' kind of social needs. Upstream is improving the community conditions in addressing those adverse social determinants of health. And the parable goes like this in the public health field is, oh my God, there's these babies that are just floating downstream, and I'm downstream just pulling the babies out of the water, trying to save them, trying to save them. There's all these babies, just like pulling them out, working with all the people, trying to get these babies out of the water. All of a sudden, one of the guys pulling the babies out of the water starts heading upstream. And we say, what are you doing? Like, there's these babies, like, what's happening? And this person says, I am heading upstream to see who's throwing those babies in the water, because I'm gonna stop them from throwing those babies in the water, right? So we don't have to pull so many babies out of the water downstream if we could stop throwing the babies in the water upstream. And it's just a common parable that we use as an example, and you can see where social determinants of health fit in this upstream impact. If we can address those, we won't have as many clinical needs downstream. So I'm going to talk about a few projects that I've worked on over the years and kind of the upstream support. So we shared the data about employment for people with disabilities, or people with autism. So unemployment, underemployment, very high in the autism community. Some data gets thrown around. The only data I know of is from the National Longitudinal Transition Study that was done by Paul Shattuck, and that says that only 54% of young adults with autism under 18 to 25 have ever worked for pay. So that's one data point that's unacceptable. And then other data gets thrown around we don't actually have, we only have anecdotal report. I don't devalue that, but that 10% of adults with autism are deployed. And then the 38% about reported being unemployed from Ann Rue's work. So at the downstream level, right, unemployment, underemployment. So we have job coaches, right, and job developers, and transition plans that talk about employment at that individual level. Very important, right? We're trying to get each one of those individuals a job. Midstream, start talking about inclusive hiring practices. So why, if your job does not require you to sit in a room and answer questions that you don't know what they're going to be, your job will never require that, why do we use interviews for jobs when the job doesn't require you to answer unknown questions? Why don't we apply practical interviews, applied interviews, all of those things? So inclusive hiring practices. And then again, once you have a job, how do we support inclusive promotion and retention practices? So I've also done some work on kind of helping people, managerial training, thinking about when you're going to advance someone. So once you get a job, how do you get promoted within that job if you want? And then also, how do you retain that job? Because job placement is only the first task. And then the most recent project I started on with some colleagues, with some funding from a foundation, is really trying to address the whole diversity, equity, inclusion movement, DEI. So we wanted to think about, there's been so much voice given to DEI, right? You open up Forbes, New York Times, Wall Street, doesn't matter what you open up, the DEI reporting about things and equity. And so we were trying to figure that out related to disability, not autism specific. So we pulled the diversity reports for 2020 for every Fortune 100 company. So Fortune 100 companies, if they had one, we pulled their diversity reports and then coded them. And everybody who had one, and it was the majority, I think over 70, had actually a written diversity report that the public had access to, that I could access, or I could just make a simple phone call to someone in HR and they'd send it to me as a community member, and reviewed their reports. So everybody who had a report reported on gender and race and ethnicity, everybody. So they had data reported on race and ethnicity and gender. Some people also had veterans. So some people had reporting on veterans, and every report, I will say, gave a nod to disability, meaning there was like a picture of a person in a wheelchair, or talking about putting Braille signage up in their office. One company had data on disability, and that was Google. So they were the only company who reported on the data, the percentage of people with disabilities. So one out of, but everyone knew they should talk about disability because they kind of put it in there, but they didn't report on the data. And so we are engaging in this work to, we built some tools and resources and some educational campaign to support companies in gathering and reporting disability data in their DEI reports. And our perception, our hypothesis, we're 2 years in, our hypothesis is, one, if they report, they'll feel a bit accountable. So they'll engage in disclosure campaigns, they'll want to have better numbers, all of those things. And then the other thing is they will recruit talent with disabilities because they will be perceived as a good place to work. So it's going to be mutually beneficial, right? Talent acquisition is really difficult and incredibly expensive for companies. So if they can start to recruiting talent that may not be are looking for somewhere that's user-friendly, again, we're 2 years in, looking at how that's upstream, right? Ideally, that's going to impact the unemployment and underemployment rate down below if we can get those Fortune 100 companies to start reporting about diversity, measuring diversity, addressing diversity. So that's one upstream project. We have three of the Fortune 100s that are in it with us already that have been engaged. It's a process to get through those guys' protocols, I will say. When they agree to do it, it's usually going to be a report about 3 to 4 years out. So we've got some lead measures, and the lag measures will come out when they actually do publish their disability reports. So that's an upstream intervention. Another intervention I worked on was a trans health project. This was not people with disabilities. So trans men have higher rates of, again, gynecological cancers and breast cancer. And it's because they don't get preventive care. The men don't get preventive care. So no pap smears and no mammograms. And so looking at that, trying to think about how you can help these men get preventive care. And so worked on a project with the Howard Brown Health Center, looking upstream. This was actually a midstream intervention. Transphobia is something that we all need to be addressing. We know that those of us work in autism, there's higher rates of non-binary individuals who are in the population of people with autism as well. We actually didn't go after that top tier there, but we're looking at preventive care and trying to change the practices and kind of medical experiences for trans men when they are going to get care. So patient navigation, allowing kind of trans hours, because men were saying like not really comfortable sitting around with 10 women waiting for mammograms, awkward, don't really have anywhere to, like what gown changing room do I go to for those of us that have gone and got mammograms? So kind of changing that, and we're looking at that. And our outcome measures for that were assessing the physicians' offices, so the radiographers and the gynecologists, what their welcoming kind of messaging was around trans men. We worked on that. And we were able to get more healthcare providers to be able to meet the needs of trans men, which was our measure of that. So that was a really kind of interesting project. And again, of course, trans men still need to be treated for gynecological cancers and breast cancer, but I'd really like to keep that baby from going down the water and be able to have preventive care so that they don't end up with cervical cancer. And last one, this is one I worked on during COVID, which gave us this interesting opportunity. Feels like a horrible word to talk about COVID, but let's just say all of a sudden we got this opportunity to assess telehealth in a different way and technology in a different way. So was working with a provider that serves a little over 2,000 people with autism. And so it was a big N that we had to be able to look at. And their services, their home-based services, were just kind of cut, as most of yours, you guys understand, those are working home-based, were cut because all of a sudden, we were in a lockdown. And we know that there's a dosage response for people with autism, so we know downstream that's a poor life course outcome. They don't get the proper dosage, worse outcomes. Midstream, we knew we were going to be doing telehealth, address the technology divide, ensured everyone had technology, including Wi-Fi access, which is often a barrier. So this organization was able to provide that technology divide. And so we were able to get a sample size high enough, and we were looking at kind of racism and poverty as the measures. So we used, we had a sample size that was big enough. We chose who declined telehealth and who accepted telehealth and compared them when we were looking for differences. And this is going to come out in the Journal of Telehealth in a couple months, but I will just share with you that we found nothing in our measures, which is really interesting. And our premise in some ways is if you kind of address the technology divide, it eliminates some of the racial and poverty issues because you've addressed the technology divide. So that was interesting as well, but kind of looking upstream. And then the last one I want to talk about is just kind of the overarching one of kind of autism life course outcomes. So we've got these data down at the end here on unemployment, suicidality, and thinking about working upstream. So how do we teach self-determination? I just started a new gig thinking about focusing on well-being. So if we say well-being wins, in my organization, like how do you focus on well-being, inclusive communities, and then furthest upstream, just flat out ableism, right? So how do we start talking about ableism? How do we ensure that when someone receives an autism diagnosis, the second word out of the mouth isn't "I'm sorry," right? Which is, ouch, right? Like, I've just informed you that you are lesser than by my apology in our society. So I'm sorry. And then thinking about service entitlement. So I've worked primarily in the adult population for the last 20 odd years. And most even well-meaning people in our society don't understand that adults with developmental disabilities aren't entitled to services. You're entitled as a child, but not as an adult. So VOC Rehab and Developmental Disabilities Division. So how do we work upstream to provide education and information so that service entitlement actually exists? And that's something in our overall society, we don't actually believe we haven't championed this in the United States. People are not entitled to housing. Adults are not entitled to housing. Children are entitled to housing. We ensure that children are housed. We ensure that children are fed. We believe in that, but we do not believe in that for adults. We allow people to remain unhoused, and we allow individuals. And that just kind of bleeds over into developmental disabilities in my mind. So thinking about that upstream policy advocacy work that could change that. The only state that has entitlement services for adults is California with the Lanterman Act. So one state did it. So I'm pretty sure the other 49 could do it as well. And it's not perfect, but it is an entitlement. And so thinking about how can we change that to be for all individuals. And I think part of that is related to education of the general public. They really perceive that entitlement services exist. So thinking about that upstream, I think about from a behavior analytic, often behavior analysts, we're like looking at these tiny aspects of things because of our field. Like it kind of demands this like precision around it. And sometimes we're looking at things that are just so very small, and are they important, versus kind of pulling back and looking at the bigger picture as well. Maybe how does that small thing impact the bigger thing? This is Dr. Poling from 2010, and I don't perceive it's changed at all in the last 13 years, but it appears to me that in the past decade, an increasing proportion of JABA articles are not focused on directly helping people, but rather on determining whether the same relations between environmental inputs and behavioral outputs demonstrated in experimental analysis studies hold in people with special needs. And I think I'll just use the two examples that I think about with this quote here. So we have many studies on how to teach sight words. We have very, very few studies on how to read connected text with meaning, which is what literacy is. And we read, so I'm looking at you like, that's right, Janet. And we do that because I perceive, my personal opinion, because it's easy to measure. A sight word is very easy to measure. Reading connected text is hard to measure. Measuring comprehension can be difficult for a layperson, right? And then the other one I think about related to communication and interpersonal engagement, we have many, many, many published studies on requesting because it's very easy to measure. It's very difficult to measure interverbal, interpersonal engagement, relational aspects of true communication. And so if the data we're measuring are for the benefit of the researcher, because they're easy to measure and they get really clean lines, man, we got to move that over. And it is messy. Again, it's all those lines. When you're measuring discourse versus measuring requesting, what are the variables that we're assessing? So I'm really hoping that we result in this change. So it's a call to action. Cody had a call to action for us as well. Thinking about where you're working in the stream here, and most of us do work in the number 3 there in the clinical. How do you influence upstream? How do you engage politically? How do you influence? How do you connect with others to affect those social determinants of health? How do you work collaboratively with your community colleagues? How do you build capacity to ensure that individuals have overall wellness and well-being? I want you guys to pull out your quick write again that you did around equity and what equity means to you. And I perceive most of us want to be equitable. Dr. Fryman kind of started us this morning, like thinking about why we do what we do, and that most of us have been called to this. This isn't a job for us. This is a passion, right? We do this because we love it, and it feeds our soul. And I know most of us want to be equitable in our actions. And when you're looking about what equity means to you, I ask you to apply that to your practice and ensure that you're engaging in equitable work in what we do in a profession, because I know that's what we all want to do. Thinking about what your my action is. You may already have one from Cody. I'll just ride on his coattails and have that same action. But what is our action to ensure equity? We started out for the front of this presentation talking about the inequity that exists in our society, and we can impact that. Because the idea that some lives matter less is the root of all that is wrong with the world. And I look forward to working upstream with all of you. And there's your last attendance code. Thank you.
Thank you so much for a great final presentation. And I think we all have a lot to reflect on and implement as we move forward from today's presentations. Thanks to all of you who joined us in person. It's great to see and be with people live again. And thanks to all of you who joined us virtually. You will be getting an email today, everyone, that will have directions for how to input your continuing education codes. And by Tuesday, you will be receiving links to any of them that you need to rewatch or had to step away from. And you will have until August 23rd to submit your CE codes to get credit for today. I want to thank all of you for being here with us today for this day of reflection and call to action. And I want to thank you for supporting the Cambridge Center and all the work they do for autism and all the other things that behavior analysis tries to impact. So thank you so much. Did you have anything to say, Rob? Thank you. Thank you. Safe home for those of you who are driving here, because there was quite the storm earlier this afternoon. So take care, everybody. Thanks again for joining us.